For me, life is inherently sacred, um, but also bringing to the table the first diagnosis is it's a baby. And no other diagnosis ever negates diagnosis number one.
Hello and welcome to Caring for Both, a curbside consult series by the American Association of Pro-Life Obstetricians and Gynecologists, or APLOG. On this podcast, we bring on experts who can provide insights to help you as a medical professional in your life-affirming career and your life-affirming practice. We release new episodes every Thursday. I'm your host for today, Miriam Diallo, and you might notice that our setup today is a little bit different than it usually is, and that is because I am filming here in person with today's guest because we just so happen to both be attending the 2024 Matthew Bulfin Educational Conference, which is a medical conference, annual medical conference, co-hosted by APLOG and the American College of Pediatricians, or ACPeds. So I'm very excited for this conversation today, which is going to be about caring for neonates at the cusp of viability. A little bit about that topic. As you know, physicians today are able to save babies who are born more and more prematurely. In fact, in the past 50 years, the age of viability, that is when babies can survive outside the womb with the help of medical technology, has been lowered from around 28 weeks to 22 to 24 weeks today. And that's a massive change, obviously. But one thing hasn't changed, and that's the necessity of really tough conversations surrounding whether and how to treat babies who are born prior to or right around that cusp of viability. And so I'm excited for our guest today, Dr. Robin Pierucci, to speak a little bit to that issue. Dr. Pierucci is a full-time neonatologist practicing in Michigan. On top of that, she is the medical director of a level 3 50-bed NICU. She has a master's degree in bioethics and has completed the National Catholic Bioethics Center's certificate program. This background dovetails with her research and publications and her involvement in performance enhancement projects, including neonatal palliative care and care for infants affected by in utero drug exposure. Dr. Pierucci is an associate scholar at the Charlotte Lozier Institute, as well as a board member at ACPeds, the aforementioned American College of Pediatricians, and leads their pro-life council. Dr. Pierucci, thank you so much for being here today.
It is a pleasure to be here.
Of course, it's wonderful to have you. To start off, why don't you tell our audience a little bit about how you work with these periviable neonates and as a neonatologist?
So, as a neonatologist, my entire job description is taking care of fetal people, literally as they are born during the fetal period of development, which is, and we've backed it up, as you were saying, smaller and smaller gestational ages. And so what happens is I'll usually be consulted uh, by the perinatologist to come meet with parents in a prenatal visit,
Mm.
where we discuss, boy, what should they expect? And depending on the age, gestational age that I'm meeting them at, we have to have very honest, well, we always have to have very honest conversations, but it's different at different gestational ages of what do we worry about? What sort of expectations should they have?
Mm. Yeah, that's it's really important to kind of set up the conversation. And as I mentioned before in your bio, you are pro-life. So how do your pro-life views affect how you approach care for these babies and their families?
So for me, life is inherently sacred, um, but also bringing to the table the first diagnosis is it's a baby. And no other diagnosis ever negates diagnosis number one, which is so important because with the increased amount of fetal diagnoses, we have people not only because of edge of viability, but also because they're concerned about they have been told there's an abnormality that we get consulted. Um, and I get to say, remember, tell me your baby's name. Have you chosen that yet? Um, because it's a promise of, I'm going to walk through this with you no matter what. We're going to let the baby determine how much or how little we should do. If the baby responds to treatment, then we go this way. If the baby doesn't respond, then we're going to go a different direction, but you're not going to walk alone. Um, so it really is my privilege to get to help navigate those waters so that no parent feels like they're making life and death decisions. Um, no, no, I don't decide life and death. They don't decide life and death. We're going to see where the baby takes us, and we'll follow that lead. Mm,
Absolutely. So it's really about really valuing that baby's life and keeping a clear focus
mhm.
on the value of that baby's life throughout your care for
Uh,
for them and for their parents.
Absolutely. It's interesting. I've had mothers be very concerned about them their obstetrician isn't pro-life, and they make it sound like they have to either terminate or it's allowing the baby to suffer and then will still die. That's not informed consent.
Mm,
That's not telling the full story. First of all, fetal diagnoses, rare they we have a chance of being correct, but they're not 100%.
mm,
And it for sure doesn't tell you about prognosis. How is the baby going to do? I don't know that until we meet the little one. So even in particular at the edge of viability, at those 22 weekers, we talk about what are the risks. So we're very honest. We need IV access. Without IV access, we're helpless because you can't just give them pizza. You can't, or even just immediately to full breast milk. So there's risk. We need IV access. Infection is a huge risk. They're born without an immune system. Um, and also those lungs are so immature. I look at ventilators now as a necessary evil. Yes, I like them and I need them, and then I want to get the babies off. But if we have to be able they have to be big enough for us to get the right tubing in to be able to at least briefly be on the ventilator. So warning people about it's a long road, but this isn't, I wouldn't even call it aggressive medicine anymore because we're not just being able to have babies survive, they're surviving healthier than I've ever seen before. I'm sending 22 weekers home without any medicine, maybe a nasal cannula, but often not. I never take it for granted. There certainly are little ones that those outcomes haven't been what everyone would hope. Regardless, we're not going to abandon ship.
absolutely.
How do we walk with you?
Yeah, you have to walk with the parents and you have to tell them all the information that they
Right.
deserve to know.
And discover their values. It's not just me saying, just because I think life is inherently valuable, they have to be permitted to where are they in their spectrum and what can they handle at home. That's just good medical ethics of caring for the unique family situation, as opposed to you have to do this or have to do that. No, no. What I do have to do is offer the very best care I can.
Right. To backtrack a little,
Mm,
what does it look like? What's your initial touch point with these parents? I assume it's when they realize they're at risk of delivering prematurely.
right.
And what does that initial consult generally look like?
So that, like I said, the initial consult in an ideal world, it's really is prenatally, but sometimes mom's in danger of delivering delivery and she's already up on the floor. She's already been admitted in
Mm,
preterm labor. So sometimes I'm literally sitting bedside in the hospital room, and sometimes it's already after the baby's been born because it's so emergent. We have an emergency C-section, and the team just goes back. So uh, um, ideally, we have a chance to talk. Mostly, I'm hoping to build trust that we're not going to do things to the baby. We're and cross that boundary. It's how do I work with the little one? And once again, always describing here's what a treatment plan looks like, and here's what responding looks like. Here's what not responding looks like, and here's the next thing in my bag of tricks. What do we have left to offer?
mm.
Um, so once again, and it's a partnership. That's so essential in those prenatal conversations. They are part of their baby's medical management, including the parents in, and even after birth when these little guys are about the size of your hand. Yes, you can touch your baby. In fact, your little one needs you to. the babies do better when I have parents at the bedside. So getting to say, no, that's not nice. No, that's really the medical facts. Um, your little one doesn't ever not need you. And the babies recognize the parents. So being able to tell them those things is a huge part of the prenatal consult.
That's really important, and it's really about kind of bringing the whole family into the care that you provide.
Oh, I love inviting not just mom and dad, but if there's important people that help them make decisions, whether there's elders or other partners, how come everyone in? How do we include
Right.
everyone? Because one of the more uncomfortable situations is when you have like Aunt Betsy calls in from the coast who's never seen the baby and is like, well, why aren't you doing this and this? I'm like, no, no, here, let me bring you up, in um, because that's hard. And I don't want the parents to be made put in a position of being the medical translators.
Right.
I'm like, that's not fair. How do we help? So
Right.
once again, it's taking care of the whole family unit.
Absolutely, because they shouldn't be alone in making
Right.
those kinds of decisions. To touch back on something that you mentioned
Mm,
before, how would you say your approach to care might differ from those of neonatologists who don't share your pro-life views?
hmm. Unfortunately, if you don't find life inherently valuable, I think you can be a self-fulfilling prophecy. Meaning, if you don't think this baby's going to make it, chances are they won't. And whether that's at the edge of viability or another fetal anomaly, if you don't think we should be offering care, then it's not going to happen. One of the biggest areas where there's actually quite a bit of research is babies with trisomy 13 or 18.
Mm,
Now, I would never underestimate how much medical help these kiddos need, but they're not worthless. The families that get them home absolutely adore them and will tell you how much their other children love them. Um, they're still precious. But we were taught in medical school that that's a fatal diagnosis. And there are a number of beautiful studies that say, first of all, it's not fatal because we're following these kids out to 10 years, 15 years, and beyond when we choose to intervene. Now, is that all of them? No. But we don't even know what we don't know because we were all taught don't do anything.
mm,
So that's what I mean by being a self-fulfilling prophecy. We can, if I don't intervene, yes, a little one their demise can be quicker. If we try, let us see what we have the ability to do. So that's why trying to come at this with this life is precious. I'm going to take my orders from the baby, and then we'll decide what we do next.
you can see some really beautiful outcomes when you choose to do some interventions in the first place.
Yeah.
Absolutely. A related topic that
Mm,
you have some expertise in is perinatal palliative care. Can you
mhm.
tell a little bit? Can you tell us a little bit about what that is?
Sure. So once again, it is with serious humility that we get to do this. Perinatal palliative care, when done well, is about how do you live with something I can't heal? How do if getting home is important, how do we do that? Um, what do we need at the bedside? Because once again, I don't have a crystal ball to say how long we have. And sometimes it's years. Sometimes it just means, okay, let's get all the right people involved. And sometimes it's how do I build that story of that life um, in what precious moments we have. So perinatal palliative care spans everything from there's a photographer that volunteers to come in called Lay Me Down to Sleep,
Mm,
and they take pictures. So you have the album of this baby's life. And I've invited them into the C-section room. I've had videos of baptisms at the bedside or other ceremonies that are important. How do we take advantage of those milestones? Same thing with family pictures. If a baby's in the unit for a long time, we're just not ready to go home. How do we celebrate the other siblings' birthdays? And up in our atrium, we've had balloons and cake and other things. And um, once again, how do we celebrate an entire family unit? Um, because it's never just about the single person.
mm,
This we have this kind of weird notion it's a very American a worshiping of autonomy.
Mm.
We don't make decisions about just us. We do it in the context of our
Mm.
families and how do we include everyone. So perinatal palliative care helps remind us how do we take care of people medically, but spiritually, social economic, all of the factors that go into, in particular, when there's something I can't necessarily heal,
Mm.
but the answer abandoning is never appropriate.
Right, right. So it's a very holistic service because those
Correct.
kids' lives matter, but they also matter to their families, to the
Of
communities around them.
course.
So,
One of the things that um, I become more aware of as the prenatal diagnoses have increased is sometimes just having a prenatal diagnosis, we sometimes do less. And
mm,
that's where I get worried about calling perinatal palliative care too soon. Because once again, we're back to that self-fulfilling prophecy.
right,
There's actual studies that show if you get the same diagnosis prenatally as you do postnatally we tend to treat them like a regular baby until we figure out, okay, there might be something else going on.
mm,
And so it always is with a sense, once again, of that humility and caution, but love of the person in front of me, that sometimes knowing more doesn't necessarily lead us to doing as much as we can. I worry we can sometimes hold back when we haven't confirmed a diagnosis or know the spectrum of disease until we give the baby a chance.
right,
So it's a tough line to
right.
walk, and I can't even tell you how I've always done it right. Um, I show up to get to try to love them and provide medical excellence every time.
Certainly. So yeah, there's definitely a kind of balancing act of
Yeah,
wanting to provide them with comfort measures if you're fairly certain that they're
right.
reaching the end of their life versus not wanting to uh, call it too soon or
Nobody wants to prolong suffering.
right,
That is not what we're about. On the other hand, I also I want to give the baby a chance to respond.
right.
But then we have really good meds how do we keep this little one as comfortable as we possibly can
Mm.
and in their parents' arms where there isn't anywhere better to be.
Absolutely. This has been a really fascinating topic, and I'm sure we could do a whole nother episode just on perinatal palliative care. But yeah, for now we'll close out. Thank you so much, Dr. Pierucci, for coming on to share your insights.
My pleasure.
And yeah, and thank you so much to our audience as well for joining us. If you like this episode, be sure to give us a like on YouTube and subscribe to our channel. Or if you're listening on a podcast app, give us a 5-star review. We're really grateful to have you on, and we hope to see you next week.